My name is Caitlin Omer, and I'm going to be presenting my neuroanatomy case study for Dr. Natalie Leonard's neuroanatomy and physiology class. So I was assigned case number 8, and it had the following details. A 35-year-old housewife came to her physician because she was experiencing numbness in her hands. She was concerned because she had burned her right hand on the stove but had not felt it. On examination, it was seen that she was severely burned on the palm of her right hand, her thumb, and her index finger. She did not respond to pinprick or temperature differentiation on the dorsum or palms of either hand. 6 months later, an examination revealed further sensory loss of the same type, which had progressed up to the shoulders. There was also a general weakness of the musculature of both upper limbs that was most prominent in the intrinsic muscles of the hand. My diagnosis for this case was type 1 Chiari malformation with development of syringomyelia and central cord syndrome. So just for some historical relevance, it was first described by John Clellan in 1883, but then it was later classified by Hans Chiari in 1891. Some characteristics are anatomic anomalies regarding the cerebellum, brainstem, and craniocervical junction. Normally, there is a downward displacement of the cerebellum and even potentially the medulla into the spinal canal. This occurs during development. There are 4 different types of Chiari malformations. However, the one specifically relating to this case is type 1, and that's due to abnormally shaped cerebellar tonsils with displacement below the level of the foramen magnum. So it's important to note here that not only are the cerebellar tonsils misshaped, but so is the lower occipital bone near the foramen magnum. It's causing pressure on those cerebellar tonsils and pulling them down. So just for some extra fun facts, but the prevalence within the general population of type 1 Chiari malformation is less than 1,000, and they normally are not detected. Normally it's a coincidence among patients who are undergoing diagnostic testing for unrelated reasons. So some clinical manifestations are elevated intracranial pressure, cranial neuropathies, brainstem compression, myelopathy, cerebellar dysfunction, and syringomyelia. Some signs and symptoms are severe head and neck pain with occipital headaches made worse by coughing, sneezing, or straining, loss of pain and temperature sensation of the upper torso and arms, loss of muscle strength in the hands and arms, and spasticity and balance problems. I highlighted the ones in red that the particular patient in this case study were experiencing. So to start off with syringomyelia, it is a fluid-filled cyst or cavity within the spinal cord. As the fluid cavity expands, it can displace or injure the nerve fibers inside the spinal cord. The cerebellar tissue displacement will obstruct the flow of the CSF at the foramen magnum, therefore causing pressure to build up. This can normally result in loss of sensation in an area served by several nerve roots. So as you can see here in this image, it is a fluid-filled cyst. It creates a cavity within the spinal cord. Here it's depicted in the neck region, the cervical spine, which is also where this patient had it. This is just another example. This is an MRI where you can clearly see the syrinx. So some patients actually develop something called a hollow cord syrinx. This is when the syrinx takes place over the entire spinal cord. It spans all the way down. So you can see this dark color here. This is an entire cavity inside the spinal cord. Another complication with type 1 Chiari malformation, especially in this case, is central cord syndrome. It's depicted here at the top. And it's a loss of motion and sensation in the arms and hands due to incomplete traumatic injury to the cervical spine. It's the most common form of spinal cord injury, and it's often associated with syringomyelia. So just to connect this entire case with what we've learned in class. So just to relate this back to everything that we've learned in class up until this point, I chose one of the main affected regions as the lateral spinothalamic tract, and that's because she failed the pinprick test. She couldn't detect when someone was putting a painful stimuli on her skin, and she also couldn't detect temperature change. So those two inabilities led to my conclusion that she's got something going on with A delta C fiber. She's unable to transmit pain, sensory emotions to the brain. So it's going to affect the lateral spinothalamic tract. On top of that, it's also going to affect the lateral cortical spinal tract because she has, again, loss of pain and temperature perception in the bilateral upper extremities, but it's also affecting her lower motor neurons because she had a decreased ability to move like intrinsically on her hands. Her intrinsic function is decreased. She has a weakness in her musculature of both upper limbs, and it's continuing to decrease. Her symptoms are worsening. So it could be due to the syrinx getting larger, becoming more fluid filled. And I say C5 to C8 because of the following image. The dermatomes line up with every region that she's complaining of. So the entire palm of the hand, she didn't feel the burn. She's having problems moving her fine muscles within the hand. So we have the C6 region covered, C7, C8, and also C5, which goes all the way up to the shoulder. And this is going to go for both arms. So another image that I put in here was of central cord syndrome, just kind of a breakdown. And I did this to show the effects of what happens on the lateral spinothalamic tract. So we'll have injury to the gray and white commissures around the spinal cord, and it's going to inhibit her ability to feel any kind of pinprick or pain. And this is common because that syrinx is going to block off any kind of nerve roots coming out from that cervical spine. So as far as diagnosis and treatment, you want to get an MRI, sagittal, coronal, and axial views of the brain, along with the sagittal and axial images of the entire spinal cord. Another image, if a patient isn't able to undergo an MRI, they can order a CT. You want one that's high resolution with sagittal reconstructions, and you can sometimes do a CT myelogram, so they'll inject dye into the spine of the patient and it'll allow them to see the cord, and if it is compressed and wear, it also will highlight that syrinx a lot more if there is one present. So as far as your treatment, surgical intervention, you have posterior foramen magnum decompression. There's an image below of this. So what they'll do is they'll go and remove a large portion of the occipital bone, and this will allow that cerebellum to not be compressed, and it'll bring it back up into its normal place. They can also do a shunt. It's normally placed when a posterior decompression has failed due to syrinx enlargement. However, some surgeons prefer shunt over decompression due to obviously the less invasive nature of the procedure. Sometimes decompression is unavoidable due to the severity of the bony decompression within the occipital bone. Overall, the goal for the posterior foramen magnum decompression is to relieve that cranial cervical junction and to restore the normal flow of CSF to the region near the foramen magnum. So this is just another image depicting what, like, pre-surgery and post-surgery. The foramen magnum is kind of narrowed off here. You can see this occipital bone kind of sticking forward. And then after the decompression, they go and remove a large portion of that. So unfortunately, the back of your skull is it's left in a very dangerous place because if you get hit there, you'll get severely injured. But it does decompress the cerebellum. And those are my references. This is the end of my presentation.